Good afternoon, our dear students. Today we study a new cycle of lectures for students of fourth year but groups who have a first semester of fourth year. And this year you have a new discipline that named internal medicine with endocrinology. And we studying exactly from endocrinology. It is a little bit separate discipline from the all medicine. That's why it will be studying of our discipline. In the end of this semester, you will have a final control about endocrinology. And it will include 4 lectures and some part of practical classes. You will finish it nearly in the middle of the semester, and after it you will start another cycle. It will be gastroenterology. But in the as I said previously, in the end of semester you will have a control for endocrinology, and next semester in the autumn you will finish gastroenterology, and it will be pulmonology and hematology. And in the end of study year, next winter, you will have a final module from all internal medicine, all these parts of internal medicine with endocrinology, the total control. And some rules, general organizational moments in my lectures. Due to a war, due to Russian aggression against Ukraine, you know that all study process now in our university is online, except of programs in Ivano-Frankivsk for practical classes, but all lectures it's still online. And in our department, especially for this discipline, all lectures will be placed on my YouTube channel, which named Maria Brinza. And here, according to your schedule, you will see all your lecture by your thematic plans. And as I said, we start our plans from endocrinology. And topic of our today's lecture, it is essential of diagnosis, treatment, prevention, and of major endocrine diseases. And today we're going to discuss one of the most widespread disease, and one of the most important, one of the most dangerous internal disease. It is diabetes mellitus. And one more moment for all students who listening my lecture, I recommend you to write in comments your name and group number for controlling of attendance of my lectures. Let's start our today's material. Plan of our today's lecture is to give definition, epidemiology, mechanisms, classification, clinical presentation, diagnosis, treatment, prognosis, prophylaxis, abbreviation, and diagnostic guidelines for diabetes mellitus. Let's give definition. Diabetes mellitus, or DM, we will use abbreviation during this lecture, or just diabetes. It is a group of chronic, often debilitating and sometimes fatal, incurable, costly and increasing, but largely preventable, non-communicable metabolic disease that causes high blood sugar glucose levels when the body is unable to produce or effectively use insulin, with unique multi-system complications of microvascular endpoints, including retinopathy, nephropathy, neuropathy, and macrovascular endpoints in forms of ischemic heart disease, stroke, and peripheral vascular disease. There are 3 main types of diabetes mellitus. Type 1, it is insulin-dependent diabetes mellitus or juvenile diabetes mellitus. It results from the pancreas failure to produce enough insulin. and type 2 or non-insulin dependent diabetes mellitus or adult onset diabetes mellitus. It begins with insulin resistance when body cells fail to respond to insulin properly. Gestational occurs when pregnant women without previous history of diabetes mellitus develop high blood sugar levels. Epidemiology. As I said, the diabetes mellitus is one of the most common endocrine disorders and one of the most common disorders at all in a whole world between the adult population. It affecting almost 6% of the world's population, such a big number of patients. The number of patients will reach 300 million in 2025 year, according to International Diabetes Federation. More than 97 of these patients will have type 2 diabetes mellitus. It is the most often form. Here the distribution of diabetes in a world in different countries, and you see according to color what countries suffer more from diabetes and what countries suffer less. And we see that usually it depends on current economical status, and as higher economical status, economical development of the country, as higher rate of diabetes is there. Risk factors for type 1 diabetes mellitus. It is family history, it is environmental factors, exposure to viral illness, the presence of damaging immune system cells like autoantibodies, dietary factors, low vitamin D consumption, early exposure to co-milk formula, and exposure to cereals before 4 months of age. Geography, more sensitive for diabetes mellitus type 1 is Finland, Sweden, or North European countries. For type 2, it is family history too. It is a race of patients, blacks, Hispanics, American Indians, Asian Americans are more in higher risk than another races. Age, when risk increases with age, gestational diabetes, polycystic ovary syndrome in women, high blood pressure, abnormal cholesterol, and triglyceride levels. Gestational diabetes, the risk factors for it is family or personal history, nearly here factor the same with diabetes mellitus type 2. It is a race the same with type 2. Black, Hispanic, American, Indian, and Asians are more likely to develop gestational diabetes, the same with type 2 diabetes. Age, women older than 25, pregnant women are in higher risk to gestational diabetes than younger women, and weight, being overweight before pregnancy increases risk of gestational diabetes. By etiology, type 1 diabetes is characterized by loss of the insulin-producing beta cells of the islets of Langerhans in the pancreas, leading to insulin deficiency. The majority of type 1 diabetes is of the immune-mediated nature, in which a T-cell-mediated autoimmune attack leads to the loss of beta cells and thus insulin. Sensitivity and responsiveness to insulin are usually normal, especially in the early stages. Type 1 diabetes mellitus can affect children or adults, but was traditionally termed juvenile diabetes because children are more often, because a majority in children. Type 1 diabetes mellitus can be accompanied by irregular and unpredictable high blood sugar levels, frequently with ketosis and sometimes with serious blood sugar levels. Type 1 diabetes is partly inherited with multiple genes, including certain HLA genotypes, and can be triggered by one or more environmental factors such as viral infection or diet. For example, such protein like gliadin that present in gluten can be a factor of provoking of diabetes mellitus type 1. Type 2 diabetes mellitus. It is characterized by insulin resistance, not deficiency from pancreas, but insulin resistance, which may be combined with relatively reduced insulin secretion. The defective responsiveness of body tissues to insulin is believed to involve the insulin receptor. In the early stage of type 2, the predominant abnormality is reduced insulin sensitivity. Type 2 diabetes is due primarily to lifestyle factors and genetics, obesity, lack of physical activity, poor diet, stress, urbanization. Dietary factors also influence the risk of developing type 2 diabetes mellitus. Sugar-sweetened drinks, saturated fats, trans fatty acid, white rice. Gestational diabetes, its etiology, this diabetes resembles type 2 diabetes mellitus in several respects, involving combination of relatively inadequate insulin secretion and responsiveness, and occurs in 2–10% of all pregnancies. After pregnancy, approximately 5–10% of women with gestational diabetes are found the most commonly type 2 diabetes mellitus. Gestational diabetes is fully treatable but requires careful medical supervision through the pregnancy. It can damage the health of the fetus and mother and risk the baby to include macrosomia, it is high birth weight, congenital heart and central nervous system abnormalities, skeletal muscle malformations, respiratory distress syndrome, and red blood cell destruction. Mechanisms of diabetes, and we started from the type 1 diabetes mellitus because here the mechanisms is the most bright. You learn it on pathophysiology, and now we discuss it in type 1 diabetes mellitus. And most of this moment are actual for type 2 as for gestational diabetes, but not all. We will stop on it. Type 1 diabetes, it is a culmination of autoimmune inflammatory lymphocytic infiltration with destruction of insulin-secreting beta cells of the islets of Langerhans in pancreas. As beta cell mass declines, insulin secretion decreases until the available insulin no longer is adequate to maintain normal blood sugar glucose levels. Type 1 diabetes mellitus. After 80–90% of beta cells are destroyed, it is nearly all cells are destroyed, it develops hyperglycemia. One more time, if the part of cells are destroyed, another part is enough to compensate this situation, and it will be no hyperglycemia, no diabetes mellitus. And just in case when it is all beta cells are destroyed, or 90% are destroyed, just in this case patient present with hyperglycemia and diabetes mellitus. Polymorphism of the class 2 human leukocyte antigen, which we named HLA system genes that encodes DR and DQ, are the major genetic determinants of type 1 diabetes mellitus. We told in a risk factors that genetics one of the most important predispositions. Here are the mechanisms of autoimmune attack against beta cells. You can make for yourself a screen and work with it individually. Complications. Patients with diabetes mellitus suffer most of all not from directly hyperglycemia, but patients get a lot of diseases, a lot of complications, and even death from complications of this hyperglycemia and diabetes. And it is several groups of complications. One of it is neuropathy or damaging of peripheral nerves. It can be sensory and autonomic neuropathy in people with diabetes mellitus and caused by axonal degeneration and segmental demyelinization. Many factors are involved, including the accumulation of sorbitol in peripheral sensory nerves from sustained hyperglycemia. Motor neuropathy and cranial mononeuropathy result from the vascular disease in blood vessels supplying nerves. Microvascular disease causes multiple pathological complications in people with diabetes mellitus. Hyaline atherosclerosis, a characteristic pattern of wall thickening of small arterioles and capillaries, is widespread and responsible for ischemic changes in the kidney, retina, brain, and peripheral nerves. Atherosclerosis of the main renal arteries and their intrarenal branches causes chronic nephron ischemia. Vitamin D deficiency is an important independent predictor of development of coronary artery calcification in individuals with type 1 diabetes mellitus. Angiopathy. Its pathophysiology mechanisms of angiopathy include several links, several steps according to this scheme. You see that it goes from normal capillary, that due to hyperglycemia it leads to basement membrane thickening, to increased vascular permeability, to capillary closure and ischemic damage of tissue. Nephropathy, it is a type of angiopathy, especially it connected with microangiopathy or damaging of small arteries and arterioles. And one of the most important organs that suffer from such type of angiopathy is kidneys, which we name diabetic nephropathy. In the kidneys, the characteristic wall thickening of small arterioles and capillaries leads to diabetic nephropathy, in which characterized by proteinuria, glomerular hyalinization or Klinefelter-Wilson syndrome, and chronic renal failure. Exacerbated expression of cytokines such as tumor growth factor beta-1 is part of the pathophysiology of glomerulosclerosis, which begins early in the course of diabetic nephropathy. Single nucleotide polymorphisms affecting the factors involved in its pathogenesis appear to influence the risk for diabetic nephropathy in different people with type 1 diabetes mellitus. Here you see, according to time, the natural history of nephropathy, and during long time, and you know that diabetes, it is incurable disease. Patients live with this disorder a long year, and during this long year after the starting of diabetes mellitus, it's all okay. Patient is asymptomatic due to nephropathy, but laboratory we can find a hyperfiltration, and in analysis it will be microalbuminuria and even macroalbuminuria, and this process asymptomatic can go 15-20 years usually in the middle. Of course, it is individual and dependent on severity and controlling of diabetes. In some patients with controlled diabetes it can be much more longer. In some patients who not control diabetes it can be even unfortunately shorter. But in the middle period is 20 years, and after it, in a continuous damaging of glomeruli, it's starting clinical part with azotemia and renal failure. It usually goes for 5 years. One more time, independent on the treatment. If it is good treated, it can be longer. If it is non-treated, it can be much more shorter. And after it, it goes end-stage renal disease. It is patients that got hemodialysis. Usually the period of life of this patient, unfortunately, nearly 1 year. Here on this slide you see histological comparison of healthy glomerulus and glomerulus in diabetic nephropathy. One can notice an augmentation of the mesangial matrix. The matrix appears in a light pink and has nodular structure on the picture, and capillary lumen is obstructed in a right picture with diabetic nephropathy. this condition called complete glomerulosclerosis. And we divided two main types, 1 and 2. But sometimes we can see a patient with a very specific type that we name a double diabetes. We can see it in areas where types of type 2 diabetes and obesity are high. Individuals with type 1 diabetes may share genetic and environmental factors that lead to their exhibiting type 2 diabetes mellitus. Features such as reduced insulin sensitivity, if it present from the starting of the disease, as reduced insulin sensitivity and reduced insulin production, we name it double diabetes. Sorry. Mechanisms for type 2. What are the different? Type 2 characterized by combination of peripheral insulin resistance and inadequate insulin secretion by pancreatic beta cells. Insulin resistance, which has been attributed to elevated levels of free fatty acids and pro-inflammatory cytokines in plasma, leads to a decreased glucose transport into muscle cells, elevated hepatic glucose production, and increased breakdown of fats. A role of excess glucagon can't be underestimated. Indeed, type 2 diabetes has an islet paracrinopathy, in which the reciprocal relationship between the glucagon secreting alpha cells and insulin secreting beta cells is lost, leading to hyperglucagonemia and hence of consequent hyperglycemia. With prolonged diabetes, atrophy of the pancreas may occur. Here is a schematical mechanism. Beta cell dysfunction, it is a major factor across the spectrum of prediabetes to diabetes mellitus. Beta cell dysfunction develops early in the pathologic process and does not necessarily follow the stage of insulin resistance. A singular focus on insulin resistance as the be-all or end-all is gradually shifting, and hopefully the better treatment options that address to beta cells pathology will emerge to early therapy. Schematically, mechanisms of beta cells dysfunction. The progression from normal to abnormal glucose tolerance, postprandial blood glucose level increased first. Eventually, fasting hyperglycemia develops as a suppression of hepatic gluconeogenesis fails. During the induction of insulin resistance, such an occurs in high-calorie diet, steroid administration, or physical inactivity, increased glucagon levels and increased glucose-dependent insulin-trophic polypeptide or GIP levels accompanying glucose intolerance. The postprandial glucagon-like peptide 1 or GLP-1 response is unalterated. Insulin resistance means the signal insulin gives to cell is weakened. This results in less glucose uptake by muscle and fat cells and reduction in insulin-mediated activities inside cells. Compounding this problem, there is additional defect in insulin production and secretion by the insulin-producing beta cells in the pancreas. Genome-wide association studies of single nucleotide polymorphisms have identified a number of genetic variants that are associated with beta cell function and insulin resistance. Some of this SNP appears to increase the risk for type 2 diabetes. Over 40 independent lots demonstrated associated with increased risk of type 2 diabetes have been shown. Mechanisms of gestational diabetes. In the maternal, pancreatic insulin response is inadequate maternal and then fetal hyperglycemia results that are the most significant source of the accelerated growth exhibited by the fetus. Surging maternal and fetal glucose levels are accompanied by episodic fetal hyperinsulinemia. Fetal hyperinsulinemia promotes excess nutrient storage, resulting in macrosomia. The energy expenditure associated with the conversion of excess glucose into fat causes depletion in fetal oxygen levels that are accompanied by surges in adrenal catecholamines, which in turn cause the hypertension, cardiac remodeling, and hypertrophy stimulation of erythropoietin, red cell hyperplasia, and increased hematocrit. Here you see mechanisms of gestational diabetes on the picture. Classification. We said several times, let's remind that American Diabetes Association lead diabetes on a lot of times, but three main of it that we discussing today. It is type 1 diabetes mellitus or beta cell destruction, usually leading to absolute insulin deficiency. It is immune mediated and mostly idiopathic. Type 2 diabetes mellitus, it is ranging from predominantly insulin resistance with relative insulin deficiency to predominantly an insulin secretory defect with insulin resistant. And gestational diabetes, it is diabetes diagnosed in the second or third trimester of pregnancy that not clearly overt diabetes mellitus. Other specific types of diabetes, it is genetic defects of beta cells, genetic defects in insulin action, diseases of exocrine pancreas, endocrinopathies, drug or chemical-induced diabetes, infections, uncommon forms of immune-mediated diabetes mellitus. Other genetic syndromes sometimes associated with diabetes mellitus, impaired glucose tolerance and impaired fasting glucose, or these two types we usually name pre-diabetes. According to international classification of disease, it placed in chapter 4, endocrine, nutritional and metabolic disorders, and by the codes E10 and E11 we see type 1 and type 2 diabetes mellitus. Diabetes mellitus in pregnancy or gestational diabetes we can find in another chapter that connected with pregnancy, childbirth and puerperium by the code O24. Signs and symptoms. The classical symptoms of untreated diabetes are weight loss, polyuria or increased urination, polydipsia, increased thirst, and polyphagia, increased hunger, that may develop rapidly weeks or months in type 1 diabetes, while they usually develop much more slowly and may be subtle and absent in type 2 diabetes. Several other signs and symptoms are not specific to diabetes mellitus and include blurry vision, headache, fatigue, slow healing of cuts, and itchy skin. Prolonged high blood glucose can cause glucose absorption in the lens of the eye, which leads to changes in its shape, resulting in vision changes. A number of skin rashes are collectively known as diabetic dermatomes. Here you see by picture, on the picture, the visualization of the most typical symptoms of diabetes. It is weight loss, extreme tiredness, increased hunger, thirst, frequent urination, tingling of numbers, blurred vision, unhealed wound, and just for fun, urine attraction ads. Why? Because it contains glucose. For objective examination, sometime additionally I give schemes of clinical symptoms on the body of patient, and you remember that objectively we usually examine the patient from upper to down, and for your notes, for your mind, for what pay attention during patient investigation. Yes, central from the upper central Symptoms: it is polydipsia, polyphagia, lethargy, and stupor maybe. It can be blurred vision, it can be smell of acetone in breath, it can be systemic weight loss, respiratory symptoms, it can be coarse mouth breathing in type 1, gastric, that is more usual for type 1 too, it is nausea, vomiting, abdominal pain, and it can be urinary changes like polyuria, glucoseuria. And on the lecture I want you to talk more about diabetic emergencies because they are really important, they are really dangerous. You will meet it in a lot of tests, in a crock test, in a practical exams. That's why it is a moment that you should know very, very good as for your exams, as for your future practice as a doctor, because unfortunately it is a very dangerous situation and very often. First, low blood sugar is common with patients with diabetes mellitus, especially type 1 diabetes mellitus or those who are on insulin. Most of these situations are mild and not considered medical emergencies. Effects can range from feelings of unease, sweating, trembling, and increased appetite in mild cases, or more serious issues such as confusion, aggressiveness, seizures, unconsciousness, and rarely permanent brain damage and death in severe cases. Moderate hypoglycemia may easily be mistaken for drunkenness. It looks nearly the same. People, usually with type 1 diabetes mellitus, as I told, may also experience episodes of diabetic ketoacidosis characterized by nausea, vomiting, and abdominal pain, the smell of acetone on the breath, coarse mouth breathing, and decreased consciousness. A rare possibility is hyperosmolar non-ketotic state, in which more common in type 2 diabetes mellitus and is mainly the result of dehydration. The most typical symptoms of low blood sugar or hypoglycemia, clinical significant hypoglycemia. One more time, it is very dangerous situation that in short period can lead to death of patient. That's why always pay attention to such symptomatic. It is shaking, sweating, anxious, dizziness, hunger, fast heartbeat, impaired vision, weakness, fatigue, headache, and irritable. Here it is placed scheme of diabetic ketoacidosis. It's not very difficult. Please work with it at home. If you have problems with it, write in your questions, in comments. We will talk more about it. Here you can see we continue diabetic emergencies, and I want to talk more about diabetic ketoacidosis. Here can be in extreme hyperglycemia. It can be three different main mechanisms. It is hyperglycemia directly, it is acidosis, and ketosis, like production of ketonic acids. All of them together give diabetic ketoacidosis. It was about emergent complications or acute complication. It was hypoglycemic and hyperglycemic states, which can lead to coma and even death of patient. And let's talk a little bit about chronic complications. They are not such a bright, they can't kill patient in minutes, but every year they kill one of the most patient in a structure of internal medicine at all. That's why they are very, very dangerous. Even if we talk that they progress during a very long time. The mortality and morbidity from such complication is amazingly high. A major long-term complications relate to damage to blood vessels with the risk of macrovascular diseases development, like coronary artery disease, stroke, peripheral vascular disease. The primary complications of diabetes due to damage of small due to damage to eyes, kidneys and nerves. We name it diabetic retinopathy that results in gradual vision loss and blindness. Diabetic nephropathy that leads to chronic kidney disease. Diabetic neuropathy, diabetic-related food problems, diabetic foot ulcers occasionally requiring amputation. Proximal diabetic neuropathy that causes painful muscle wasting and weakness, and cognitive deficit. One more time schematically for your objective examination, when you examine patient, what you have to must pay attention for. Yes, cerebrovascular disease, retinopathy, coronary heart disease, neuropathy, nephropathy, neuropathy, peripheral vascular disease in the lower limbs, and ulceration and even amputation of diabetic foot. It is a main moments by chronic complication in diabetic patient. Peripheral neuropathy, numbness or reduced ability to feel pain or temperature changes, a tingling of burning sensations, sharp pains or cramps, increased sensitivity to touch. For some people, even weight of a bed sheet can be agonized. It is very painful. It can be such different manifestations of neuropathy. Moreover, it can be muscle weakness or motoric disorders. It can be loss of reflexes, especially in the ankle, loss of balance and coordination, serious foot problems such as ulcers, infections, deformities, and bone and joint pain. A lack of awareness that blood sugar levels are low, hypoglycemia, unawareness. Bladder problems, urinary tract infections, urinary retention, or incontinence. Constipation or uncontrolled diarrhea, low stomach emptying or gastroparesis leading to nausea, vomiting, bloating, and loss of appetite. Difficulty swallowing, erectile dysfunction in men. Autonomic neuropathy can be present with vaginal dryness or other sexual difficulties in women, increased or decreased sweating, inability of your body to adjust blood pressure and heart rate, leading to sharp drops in blood pressure after sitting or standing that may cause you to faint or feel lightened. Problems regulating body temperature, changes in the way eyes adjust from the light to dark, and increased heart rate at rest. Next type of neuropathy, it is specific type, it is radicular plexus neuropathy. Radicular plexus neuropathy or diabetic amyotrophy or femoral neuropathy, proximal neuropathy, affects nerves in the thighs, hips, buttocks or legs, more common in older adults with type 2 diabetes. Symptoms are usually on one side of the body, though in some cases symptoms may spread to the other side. Most people improve at least partially over time, though symptoms may worsen before they get better. This condition is often marked by sudden severe pain in hip, thigh or buttock, eventual weak or atrophied tight muscle, difficulty rising from the sitting position, abdominal swelling if the abdomen is affected, and weight loss. In mononeuropathy, when it is affected specifically one nerve. Mononeuropathy or focal neuropathy involves damage of specific nerve, and it's most common in older adults. Mononeuropathy can cause severe pain. It usually doesn't cause any long-term problems. Signs and symptoms depend on which nerve is involved, may include difficulty focusing eyes, double vision, or arching behind one eye. Paralysis on the one side of the face. We name it Bell's